Okay, hey guys, name is Rachel. Most of y'all know me. One of the pharmacists here, and today we're gonna get into fibromyalgia. We're looking at, I'm gonna kind of go through, what it is, a little bit about it, and then some things that we can help y'all with is really what we're gonna focus on. So here we have a mix of doctors and patients. So some things will be over people's heads, some things will be a little bored. I'm going to try to keep everyone kind of on the same page. At the end, we can do questions and go from there. Okay, so we're really excited. We're doing these different Fall into Health seminars. We're probably going to keep it going through next year too on different subjects. So if y'all are part of our newsletter, you'll be getting those. But we have this one, and then we're doing a gut one, or irritable bowel disease, and then also one on chronic pain as well. So a lot of different subjects coming up. This is just a medical disclaimer saying this is really just to provide you as a resource and information. Obviously, as a patient, you'd want to check with your doctor for all of this stuff, and we can work closely with doctors as well, okay? Kind of just some learning objectives so y'all can get an idea of what I'm going to be going over. So number one, signs and symptoms of fibromyalgia, the most common ones that we see. Looking at some conventional approaches and then more on the alternative approaches. What are different options that we can look at? We're going to jump into the mechanism of action, which is what I geek out on, of low-dose naltrexone, which is one of the main things we're going to be talking about as far as something that we can help patients with, and really we have seen a lot of improvement in our patients, including a lot of fibromyalgia patients. And then identify the benefits of low-dose naltrexone for fibromyalgia. So first one here is, what is fibromyalgia? So I'm sure most of y'all here are familiar, but just kind of wanted to go through it. It is a chronic pain disorder. It's defined as having that widespread musculoskeletal pain. A lot of times it can be sharp. It definitely can have some components of the neuropathy or the tingling sensations that patients get. Usually when they define fibromyalgia, it's like having that for a 3 to 6 month period. So a long period of time. So that's why they definitely have that chronic part in there versus a short time of pain. Sensitivity to touch in certain areas is also very common. Extreme fatigue is a part of it as well, and that makes it a little bit hard because it can be misdiagnosed for a lot of other disease states because of the chronic fatigue side of things, and that's such a generalized symptom, so it's hard to just look at that. The other big one on here is cognitive disruption, or even what they call the brain fog. That's another thing that patients with fibromyalgia have. Trouble with sleep, low mood, depression, that can just come from having to live with this day in and day out as well. A lot of times these symptoms are worse in the morning. They can be aggravated by things like cold temperatures, humid temperatures. Definitely stress and anxiety make it worse. All different kinds of things. How common is it? So one of the most common chronic pain conditions. So it affects nearly 10 million people in the US and 3 to 6% of the world's population. What's even more staggering is 75 to 90% of that is women. So definitely more dominated by women as far as the disease state goes. Very common for it to run in families, to have that mom who has a child, oh, my sister has it, that kind of thing. So always seeing that it may have a little bit of a genetic part to it as well. We're going to kind of jump into conventional treatment on this. So a lot of times what you'll see is they're prescribed some sort of pain medication. I've listed kind of the most common ones you see in the parentheses. You'll have opioids. They'll have them on PRN for pain. Lidocaine injections to the areas that are really causing them trouble even. Lyrica is very common as well. You can see muscle relaxants, one that they use, antidepressants that helps with the neuropathic pain. So a lot of times those are used in conjunction to the fact that a lot of times it's tied in with depression symptoms. Anxiety is another big symptom. So a lot of times you'll see patients on anxiety medications. They even do non-steroidal anti-inflammatories, even though I saw a lot of times that it doesn't really help very much when they put them on the steroids, so they end up overusing. Other things that they definitely recommend in these programs are going to be stretching, getting good exercise, because inactivity is another one that's going to cause the pain to be worse. Now, obviously you wouldn't want to over-exercise, so not going crazy intense, high-intense exercise with fibromyalgia, but it can be beneficial. I wrote some complementary therapies that also will be obviously recommended for patients. Is going to be massage, like a therapist who really focuses on the ailments that they have. Acupuncture. We also see chiropractic manipulation, yoga, anything to kind of help the body release that tension. The other things that they really focus on is getting the patient to sleep, because if they're not sleeping, more stress, and then it worsens their symptoms as well. And then the psychological support of just having the disease. There's groups, support groups, and then also just one-on-one counseling is recommended as well. So, alternative medicine approach. Now, this is going to be, this is going to be kind of more in depth. I'm not going to get super specific on all of these. We'll kind of hone in on the biggest things that we can help with, because I'm not even familiar with necessarily how to do every single one of these. Really what I want to show you is that this protocol was actually studied on, and I'll show you some figures on the success rate of doing this kind of approach and looking at the patient in a step-by-step fashion. So I just wanted to kind of present this as the different things that they did. So first thing was doing exactly what we talked about in the previous slide. Definitely addressing the pain and sleep disturbances with some sort of medication to help them right there, right now. The other thing that they looked at doing was enhancing mitochondrial function, and this kind of goes with correcting nutritional deficiencies as well. So they found that supplying the mitochondria with nutrients they require is very helpful as well. So I named the most common ones that they talked about, which is magnesium, L-carnitine, the CoQ10, and glutathione. These being the main nutrients they looked at, but I would also encourage, doing some sort of micronutrient testing to see where their deficiencies lie, because that would be beneficial as a whole as well. The third one here is balance hormones. So address any hormone deficiencies that they have. It's really kind of interesting if you think about it being a primary issue with women. And you kind of makes you wonder if maybe hormones may play a role in it a little bit more than we don't know. So balancing hormones was one of their recommendations. Treat the immune dysfunction. So that's where the low-dose naltrexone comes in, and that's where I'm going to be discussing that a little bit in more detail for y'all as well. Treat the infectious/immune components. This really comes down to, do they have an underlying infection that is worsening their condition and their symptoms going on? So kind of trying to cross off maybe some underlying viruses or even yeast infections, any toxic mold, any sort of heavy metal toxicity, those kinds of things, looking for underlying issues. Next one, addressing unique etiologies, so heavy metal, leaky gut and food sensitivities, abnormal immune activation of coagulation, making sure to do those tests as well. For us, the biggest one that we can really help patients with in these are going to be definitely the hormone deficiencies. We can always help address those, knowing which ones to look at and where they should be and what kind of replenishment is necessary. Low-dose naltrexone is a big one. That's really what our focus is looking at how this medication is really helping all different kinds of disease states. And today looking particularly at fibromyalgia. Also, we do have the ability to do food sensitivities. We do a finger prick here to test 132 different foods, and it stratifies them in 5 different, from no reaction to a high reaction, so they know which foods that they can omit for a certain period of time. So it guides food elimination, essentially. The other thing, we do have a heavy metal testing kit. I'm going to be honest, we don't do it very often just because we're not super familiar. You know, you really want to guide the patient in trying to help them rid their body of heavy metals, but we do have that to offer if a patient just wanted to see if that is an issue. And the last one here is adjust treatment as needed. And sometimes I think this is what a lot gets missed on patients. So you maybe only the first part is done and we're not looking at all the other things. So they end up being on, 5+ medications or more just to help with all the side effects of their first medication or just all their symptoms that they're going through in general. So this alternative treatment protocol was essentially used by this study group, and they did it in intent to treat randomized double-blind placebo-controlled trial. And the first one there is 72 fibromyalgia patients, and they saw that by going through each of these steps, 57% had complete resolution of symptoms, and 39 had a significant resolution, not total, but a significant amount. The second part here is the same protocol, but essentially they put these people into a computerized system. It's expanding how many practitioners were doing it. So it was about 40-something physicians that started doing this protocol. So the first number there you see is with 259 fibromyalgia patients, and then when they expanded it, they got the patient population of 4,000 fibromyalgia patients, and the percent of patients having overall improvement, significant improvement. You can see those numbers there. Y'all can read them for yourselves, but just wanted to kind of show those are very positive effects that they're getting. Not to mention the average energy level and sense of well-being for patients doubled by the 4th visit. Again, this is kind of going through the other stuff, but a little bit more outward. 10 roots causes of fibromyalgia. So this may guide even more at looking at what may be causing it. So gluten intolerance. There's a close correlation between having the gluten intolerance and fibromyalgia. A lot of these autoimmune diseases, we find that that's a big component. So doing a food elimination of gluten and seeing how the patient responds once they add that back in is always an option. Candida overgrowth. This can lead to the leaky gut as well, and be causing these patients a lot of issues if they're having that issue. I mean, signs of that, definitely the bloating, gas, but cravings of sugars, those can all be signs. Hypothyroidism, just doing their levels to see if that could be playing a role. Vitamin deficiencies, we talked about that. Small intestinal bacterial overgrowth and leaky gut. Again, the gut playing a role in inflammation that can be contributing to symptoms worsening. HPA axis dysfunction, or also known as, maybe more familiar as, adrenal fatigue. Looking at patients' cortisol levels and seeing if that may be an issue, in addition to their DHEA. Making sure that any sort of mold, any sort of heavy metal toxicity. Another thing to think about is MTHFR. Are they having trouble methylating? That could be playing a factor as well. If they're not able to detoxify, that's going to be huge for patients as well. And then glutathione deficiency, which also plays a role in detoxification. And we talked about that earlier as well, being one of the nutrients that you'd want to replenish. Okay, so now we're going to kind of get into the mechanism of action, so bear with me. Any questions so far? No? Okay, so kind of the science behind the pain of fibromyalgia. So overactivity of pain-sensing nerves. So they're very overactive. You not only have overall inflammation, but inflammation in the brain, okay? Very interesting that you have this glia that are the support and immune cells of your central nervous system in the brain, okay? And inflammation can actually activate these glia. And when that happens, that can lead to additional pain sensitivity. It can lead to these other symptoms, the fatigue, the brain fog that these patients get, the trouble sleeping. This happens because when the glia are activated, essentially they're producing more pro-inflammatory messengers out and sending more inflammation out there, and then you get these effects. So kind of going back to the glia in the brain. So what? So this is kind of how naltrexone works mechanistically in these fibromyalgia patients. So we'll kind of get into the history of naltrexone and what it is. But in the low doses, so we refer to it as low-dose naltrexone, so anywhere from 1 to 5 milligram, this actually reduces that glia inflammation response. It's going to reduce the activation of these glia, so reducing those pro-inflammatory messengers being essentially made, okay? It binds to a receptor we call the toll-like receptor number 4. And this actually is what's going to reduce those. I have the technical names for these pro-inflammatory end products. Doctors will be familiar with this, but essentially just knowing that these are causing inflammation. It also upregulates opioid signaling. So it's going to sensitize those receptors. And essentially the easier way to say that is it increases your own body's endorphins, endogenous endorphins. And that kind of plays a role of the timing that it's given. It's usually given around 9 to 10 p.m. And it's playing a role in when the endorphin release happens in the body. This actually promotes healing, it inhibits cell growth, and reduces inflammation. So again, I kind of repeated here that low-dose naltrexone acts on those receptors in the glial cells to quiet their activity. So you're decreasing that inflammation and those excitatory chemicals, essentially which are causing the oversensitization of those pain receptors, okay? So, low-dose naltrexone, originally it was approved for opioid addiction, and then also alcoholism. Those were the big ones. That's the big ones it's known for. It's actually in a dose of 50 milligrams is what you see most commonly. Can be up to 200, but mostly 50 to 100 milligrams. So that's what it's originally intended for. And throughout time, they've started doing more studies on other disease states. And you'll see there in 2005, they're doing more studies on weight loss even, and they have it combined now, commercially available in that product called Krajewski for weight loss. So just something to think about. Also, the doses that we're looking at, we categorize them as low-dose naltrexone, and I talked about that. So 1 to 5, so very, very small compared to the commercially available. So this is something that does need to be compounded by a compounding pharmacy in order to achieve those small doses that are needed and for it to be accurate. In 1985, there was a doctor who was at Harvard, and he actually treated AIDS patients. And this is kind of where the drug got more famous, I guess you could say, is because he started treating these patients that had really, really low endogenous endorphins. And he found that when he gave them the naltrexone, that they got that rise in endorphin levels. Not to mention, he also looked at their CD4 counts and saw those going in the right direction, and he had very successful results with his patient population. So that's kind of where they started making the connection. There's been more and more research. Here on PubMed, there's 600, if you look up LDN, there's 600 articles that come up. Big studies have been in MS and Crohn's disease. They have the studies for the fibromyalgia. There's more and more coming, which is nice for us to be able to have that to back us up as well. So this was a survey. This is from a colleague that we work with essentially on their patient population. Average age of the patients using it is 51. Majority are females. Dosage range can be all over the place, but most commonly we see patients started off either between 0.5 to 1.5 and titrated up to that 4.5. Usually when we're talking about higher doses, it's more targeted towards weight loss for the higher doses. And then we have side effects down here. This is also a very big positive of it, is very minimal side effects. A lot of patients don't have any issues. Biggest one we hear is vivid dreams and trouble sleeping. This usually decreases after a couple weeks of taking it. Patients notice that that's not as much of an issue. If it persists, there's things you can do like back off on the dose. If they're on 4.5, taking it down to a 3 milligram. And then other things you can do is switch it from nighttime to morning if sleeping is really an issue. You can always do that as well. This is just showing the different conditions that it's been used for in this survey specific to these pharmacies. So I just highlighted fibromyalgia, but as you can see, it's quite extensive on that. Therapeutic success rate, where patients rated it in 8 or 9 or 10, 84.2%. So very, very good success rate for many patients. Again, it's not a wonder drug. It's not going to work 100% of the time, but really what we find is the more that we're involved, the physician's involved, especially with dosing adjustments and things like that, the more success we find. This is just a person giving their story, and essentially y'all can read that. But I think this fits the bill for a lot of our patients. Is they visited. They can't even tell us how many doctors they've gone and seen and how many hoops they've jumped through. And that's the kind of patient we're looking to help, because, this has very minimal side effects, and it's worth a try to see if it can give them back some of the life that they had before. Main advantages and disadvantages. So not a very high cost, especially when you're comparing it to other medications that are utilized. Minimal side effects, we talked about those. No known abuse potential in utilizing this, and it's effective for many patients. Now I always got to talk about the disadvantages. So patients creating their own dosages. Sometimes there's like a miscommunication, and doctor will fill a 50 milligrams and patients are like trying to mix at home or biting a tablet off and stuff like that. That's not going to work. Lack of proper dosage finding experiments. So you'll find a lot of these studies, they just do 4.5. They jump right to it, and you're not getting as much difference in the dosing. And that's what we've really found is the ones that have failed our patients are the ones that have not started off on the right dose, or have done titration too quickly, or they just tried that one dose and we didn't really get to adjust it for them. So we really encourage trying to find that perfect dose for patients. No hard data on the long-term safety of it. just a newer drug, so we don't have the long-term, and not recognized by insurance company because it's for off-label uses, right? Because the alcoholism, the opioid, those are the main labeled uses for it. So, dosing protocol for fibromyalgia. We have different protocols for different disease states. This one is kind of follows suit of the traditional one, starting at a 1.5 milligram and doing that in the evening time, and then increasing by 1.5 each week up to a 4.5 milligram. I've also done a little bit slower, doing a dosage adjustment every couple of weeks, really just patient dependent. Average time to therapeutic response, it's different for different disease states. So, some things take a little longer, it'll take up to 6 months, but this one is average response was about 30 days and success rate about 85 to 88%. So good response on the fibromyalgia. I'll quickly go into some studies on the fibromyalgia. Y'all have these in your notes too, so y'all can reference them. I also put the references at the bottom so you can read those on your own. And if you do have any issue finding, the specifics, the larger studies, y'all can let me know and I can email you because I don't know if they're all free, but we have them. So this one is done by Stanford. It was a single blind placebo crossover study. Essentially, they just looked at 10 women. They did 2 weeks of placebo and then 8 weeks of that 4.5 naltrexone. They rated their symptoms daily, and 6 out of the 10 considered responders. And that definition was they'd had at least 30% or more of their symptoms reduced. And then when they looked at overall symptom reduction, it was 2.3% with the placebo and 32.5% with LDN. So that's really encouraging. And you have to remember that this is just doing the LDN portion. It's not doing all the other things we talked about at the beginning. It's not looking at nutritional deficiencies or their gut or their hormones or even adrenals. So, just with the LDN alone, getting that response is encouraging. This same group decided to make it a little bigger, and they did double-blind placebo and larger patients, 32. They did 12 weeks on the 4.5 LDN. Again, they looked at the symptoms. 57% were considered responders. They also showed improved mood, increased satisfaction for life. And then overall symptom reduction is the 18% with placebo and 28.8% with LDN. This one I just thought was very interesting because in this one they actually measured a whole list. The ones I listed there aren't even all of them, of these inflammatory cytokines that we were talking about, and they actually found that they saw a significant reduction in these cytokine levels. So actually measuring those. And then 15% reported significant reduction in the pain, and 18% reported a significant reduction overall. This one I just want to put in here. It was a case study, and it was really just someone that was followed for, it was a one specific patient, and really why I put this in here is it was done over a 6-month period, and she still was tolerating the medication very well after utilizing it for a 6-month time period. So all these studies concluded it's very hard to treat it by traditional treatment protocols, especially to help the patients get rid of their pain. It's a big one, and get back to their daily lives. So it's safe, it's effective, very tolerable, very, very minimal side effects, and not too expensive for patients. This one I really wanted to present on fibromyalgia because my mom actually has it, so I know firsthand how debilitating it can be. One of the things you may ask me is your mom on Lowdose Naltrexone? And she's not. And that kind of leads me to my next slide, this is the biggest barrier, is that it's patients with fibromyalgia frequently use opiates. they're frequently prescribed opiates. So actually 30 to 40%. And with chronic opiate use, you get even more glial activation, even more inflammation, okay? Problem is, LDN kicks the opiates off their receptors, then you get issues with withdrawal from the opiates, okay? So these are things that, this is a big drug interaction. You don't want to get a patient that's utilizing opiates and utilize LDN. The good news is there's more and more information coming out on something called ultra low dose naltrexone, okay? So this is even smaller doses.
A study on the very low dose
on the,
and actually had me on it when it started, when you had to break the pills. And
oh my gosh, I
put
can't.
them in a liter of water, and it was a pain, but it did help. But I got tired of
messing with it. Yeah. So there's a few things on here about, utilizing ultra low dose naltrexone with different opioids. But I put this thing down here of more information to come because this is huge. It's becoming more and more known and more studied because of the benefits of not only helping patients get decrease how many opiates they use, but helping them with their pain. In this very ultra low dose and combined with the opiates, they're getting even more advantages. And that's a whole nother mechanism of the LDN. So it's interesting that this drug at different doses can produce different things. We're going to be actually working on getting a protocol for the dosing of the ultra low dose naltrexone. So I want to keep y'all posted on that as well. Here, for our providers, we do have our LDN prescription template. So if you don't have this, we can give it to you. It is essentially those different dosages for the different conditions. So helping to guide the dosing and being a little bit more particular about how to dose, not dosing everyone the same for different conditions. Put this resource in there. This is a lady a doctor that I came across when researching and doing a lot of this PowerPoint. So I've not read this book, I'm going to be honest with y'all, but I thought looked interesting, made me want to go look at it. So wanted to give y'all, maybe it can give a little bit even more detail on some of those things I wasn't able to go as much in depth with. Provider education. We also have the LDN book. This is for providers and patients though. So it goes through all different kinds of disease states and how the LDN can help. We also I wanted to bring this to everyone's attention. There is an LDN app, and this is actually for patients and providers, and it tracks symptoms. Personally, we haven't jumped into using this, but I just wanted to let everyone know that this is something that's out there. And I'm not sure if it's free or you have to pay, but it is something that's gaining popularity as well as being able to track symptoms and just giving us more and more information on how people are responding. Okay. Questions? Concerns?
You always do such a good job, Richard.
Thanks, Lena. So, yeah, I think the next one we're going to be doing is on chronic pain, I want to say, next month that we're doing. But essentially, y'all can email me. Obviously, y'all can call here too, but if y'all need any of extra resources or any questions come up that any of y'all have on any of it, I can answer any of those.